Now go on to our next speaker, Dr. Vinay Gupta, who's Adjunct Professor of Ophthalmology at All India Institute of Medical Sciences, and he is going to be talking on a case of a pediatric glaucoma and how it was managed. On to you, Doctor.
Thanks, Dr. Chitra, and I must thank the AIOS for inviting me to talk on this subject of pediatric glaucomas. So I'm going to talk to you about this little child who was brought to us at 1 month of age, and this was a typical presentation of the child having large corneas, a hazy appearing cornea with photophobia, watering. But what was interesting about this family that we later realized, and which we realized about 2 years later, and for the postgraduates to understand, is that he had a cousin sister who was also affected. So this is this particular child and a cousin sister who was also affected. And this history we came to know 2 years down the line, once the child was okay and was behaving well after surgery, that they were actually both related to each other in the sense that there were two sisters married to two brothers in a remote village in Rajasthan. So here was a family where two siblings had congenital glaucoma. I'll go on to this case later on. But when you have a child who has pediatric glaucoma, you must understand that the first thing is you have to establish the fact that there is glaucoma, and so you have to measure the intraocular pressure. And in children, generally, the intraocular pressure is much lower than in adults. So when you have high intraocular pressure, let's say in a 2-year-old child, which is about 22 millimeters of mercury, you have to be getting a little worried. The next important thing is, how do you measure the intraocular pressure? So generally, the children are under anesthesia, and when there is anesthesia where the child is undergoing, there is some amount of lowering of intraocular pressure. So the measurement of intraocular pressure may be at least 2 to 5 millimeters lower than what it actually is, and this has to be taken into account when you are writing the intraocular pressure. Most of the anesthetics decrease the intraocular pressure except for ketamine, which is supposed to cause a slight rise of intraocular pressure. So as an alternative to anesthesia, there are other ways by which you can measure intraocular pressure. You can sedate the child using triclophos. You can have the child sleeping naturally and then measure the intraocular pressure. And in some older children, you can actually allow them to cooperate and then measure the intraocular pressure, which is the most physiological thing. So apart from intraocular pressure, the other important thing to understand when you are diagnosing or suspecting a child of having glaucoma is to know the axial length, because the axial length is very sensitive to intraocular pressure changes, and only a slight change of intraocular pressure can cause a significant change in the axial length. And if you know what are the axial length at different times of a child's life, then you will understand that this axial length is outside normal limits for that particular child's age. Regarding management of these children, medical therapy remains only a kind of a stopgap. And apart from pilocarpine and prostaglandins, which are generally considered safe, there are problems with other drugs, and you have to consider that when you're giving medication to these children. For example, beta blockers at a very young age, you have to reduce the concentration so that you do not get into apneas and obstructive diseases in children. But surgery remains the mainstay of management of pediatric glaucomas, which are generally, when I say pediatric glaucomas, I hear by mean primary congenital glaucomas. The surgical options in most of the cases, in milder cases, you can get along with doing a goniotomy or a bang. But in a more severe or advanced case, like in this particular child, for example, we had to do a trabeculectomy with a trabeculotomy. So you have to combine them. The results are spectacular, and for postgraduates, you can see almost the cornea totally clearing up in most of these children. Even more spectacular is the optic nerve coming back to its normal configuration from a cupping to a normal looking optic disc. But what remains is the harp striae in the cornea, which do cause some amount of photophobia in these children and amblyopia over a period of time. You have to follow up these children lifelong. You have to do their visual acuity, multiple refractions. You have to manage their strabismus, amblyopia. Some of these children may also develop cataract and may require a keratoplasty. Because these eyes are big, you may have to do a good retina evaluation as a child grows up, because generally they behave like pathological myopes and have a very high incidence of retinal degenerations and retinal detachments. So this was a 25-year follow-up of our series where we have followed up these children for long. And what we realized is, as far as visual outcomes was concerned, amblyopia, or a lack of management of amblyopia over the years, is one of the main causes of why these children do not get good vision. So even if you've done a good surgical job, the intraocular pressure is well controlled, but the visual acuity will not improve if they are not given adequate refractive correction and managed for their amblyopia. So coming back to the same child, this is how the picture is after 1 year of surgery. This was the picture when the parents brought the child, and the child is now happily moving around and playing about. So this is the story of almost like 80 to 90% of these children. And this is what the postgraduates have to realize, that there is a lot of scope in pediatric glaucomas, and they can do pretty well. But the next important thing is to counsel, not just counsel the parents regarding the long-term outcomes, but as in this case, you may have to do a counseling for the next child that is going to be born, and the parents, even if they're coming from low socioeconomic status, will have to be told that what are the consequences of the next child having glaucoma, and that can only be done when a thorough genetic testing of these children is done. For example, in this particular family, we did actually go ahead and do a genetic testing for the child. So to sum up, I would like to say that this pediatric glaucoma has great scope, and it is a good option in managing these children, and they do pretty well. We have this conference coming up, and those who are interested, in March this year, we'll have a virtual meeting of our Indian Pediatric Glaucoma Society. A lot of us have worked very hard in bringing up this program, and you're all invited to join in. Thank you.
Thank you very much, Dr. Vinay. I'm going to ask you this question. What do you think is the role of GAT or a 250-degree goniotomy in these eyes?
Yeah, so as I said, you see in very early cases where the cornea is relatively clear, where the optic disc is not so bad, these are the children who can undergo a goniotomy or even a GAT, you see, and they will do pretty well. Whereas children who have a very large corneas or a very advanced disease or a very advanced cupping, these are not the candidates for a GAT or a goniotomy, primarily because you want low intraocular pressure in these eyes. You want that optic disc to reverse, and you want it for a very long period of time, which means that you would like to do something definitive. And these are the cases where a trabeculectomy with a trabeculotomy would be a better option to go ahead with.
Dr. Shushmita, any thoughts on this? Anything you want to add?
Yeah, and it's also important to understand phenotypes, the ones that do, because pediatric glaucoma is a basket of very, very different things. So if you have a phenotype, say neonatal onset glaucomas don't do too well. And I think primarily because the dysgenesis is early in utero and the outflow channels have not developed. So that's how we understand that the angle surgeries don't work too well, and you might have to combine them. And then phenotypes like aniridia, especially if they're neonatal onset, they don't do too well. Neonatal onset CU doesn't do too well. The best candidate for angle surgery would be an infantile primary congenital glaucoma. There's no doubt about that. But mercifully, they make up more than half of our armamentarium. So if we can see it in, but phenotyping is very, very important. My take on that.
Thank you very much. Paucity of time, we need to move on.